And with that, we'll move to section 2. And my good friend and prior trainee, Dr. Emad Hakemi, who's practicing in Cleveland Clinic, Florida, is going to talk to us about undergrade wire escalation and undergrade techniques overall. Emad?
Thank you. All right, thanks a lot, Dimitri, for the invitation. Thank you, TCT India, for organizing this. So my name is Emad. I have no disclosures. The way I look at anti-gray wire escalation, it's a stepping stone to whatever comes afterwards. It's one of the initial learning skills that we have to master before we start building on that skill. And that's something that Dimitri hammered a lot during the training that I went through with him. I'm presenting a case that shows some of those skills that we're going to talk about. Bifemoral axis. This patient has, as we see, a large RCA system that has CTO in the mid segment. With some bridging collaterals, it's hard to know here or appreciate if there's actual anti-grade flow in the true lumen or just a lot of bridging collaterals. There's left to right collateral supplying RPL systems with another distal CTO in the RCA territory just before the RPL start showing up. Again, different areocrany shot showing the RPL system where the second CTO is present and actually shows the magnitude of this RCA system. We decided to go, obviously, anti-grade. This is the usual way we always try to achieve the recanalization of CTOs, turnpike microcatheter. And for this case, initially, we tried the Fielder XCA. We thought might be a microchannel that we can actually get into and advance into the more distal part of the vessel. Fielder XTA did not actually achieve that purpose. So our next wire was Pilot 200, where you make a very micro bend at the tip of it, obviously, and you start trying to reach that distal vessel, trying to get into that, staying within the true lumen of the vessel, which sometimes is not an easy thing to do. The reason we picked initially the Fielder XTA, it's a pretty low tip load wire, hydrophilic. Doesn't give you a lot of tactile feed, but pretty safe when you want to go through those micro channels, trying to avoid the bridging collaterals, because you don't want to advance those wires into the bridging collaterals, can complicate the procedure, obviously. We thought initially that this wire did not have enough tip load, so we escalated to a Pilot 200, which has a 4-gram tip load, also polymer jacketed hydrophilic wire. Not a lot of tactile feedback, but a lot of the times if you just spin the wire, it can actually find the channels you're looking for. Again, being careful not to go into those bridging collaterals. Unfortunately, also the Pilot 200 did not achieve what we wanted to achieve. So the question became, now what wire should we actually try to go? Would you go for a stiffer wire? Would you go with a less hydrophilic wire, give you more tactile feed? And you know, all these questions go through your mind when you're doing these cases. Decided to go with a Gaia 2, which is basically a 3.5 tip load wire that has a tapering end and it's pre-shaped tip, 1 millimeter bend at the end of the wire. At the end of the wire is 0.1 wire compared to the body of the wire, which is 0.14. It's hydrophilic, but it's not polymer jacket. And it gives you reasonable tactile feed. And this wire, I mean, it depends when you ask, but most of the time we try to actually steer it and direct it towards where we want it to go rather than spinning it. And this wire actually was able to go through the mid portion of the RCA CTO into the distal vessel. But as you see here, you can see some stress on the tip of the wire, making you think, okay, probably I'm not in the true lumen here. So what options do we have here? So now we traversed the first portion of the CTO, but now we're still not able to re-enter distally. If you start going through the anti-gray wire escalation, some techniques will depend on leaving this wire in place, so it works like your guiding wire, so you know where you go with the next wire. So this is called a parallel wire technique. This is one thing you can do. Other strategy you can go after is ADR, where you basically use a Stingray catheter to re-enter in the true lumen. What we opted to do before we start going into more of those complex techniques is by redirecting the wire into the true lumen. We had again, here we see the stress in the wire tip, knowing that we are in an subintimal plane. So we decided that we had a good faith that actually a lot of these procedures, you need some good faith, and in addition to your experience and luck. We had a good faith that we actually can be able to re-enter the true lumen without utilizing the power wire technique or the ADR techniques. Using the Gaia wire, in which case this is a demonstration of it. Basically, the Gaia 2 wire traversing into the true lumen. You can clearly see here that there's no stress on the tip of the wire, so you kind of feel more comfortable now knowing that you're in the true lumen. And this is a retrograde shot showing us clearly that the Gaia is now in the PDA vessel. So now we started. Basically became a case of, you dilate, you IVIS, you size your stents, and you secure that what you had just achieved with stents. And here we clearly see now the PDA system coming. There's a very short CTO that we thought those two PL systems are big enough vessels to target for revascularization at the same setting. Again, you go with a microcatheter. You park the microcatheter just before the proximal cap, and then becomes an issue. Okay, now what wire I should use? Here we don't really have micro channels to go after, so going with an XTA doesn't really make a lot of sense. You can either pick a Pilot 200, which is a relatively safe wire, which is something you usually like to do, going safer wires first, or you go with heavier tip load wires. In this case, we attempted the Pilot 200 to puncture the proximal cap and the distal cap into the true lumen. That did not succeed. Again, the Gaia 2 was the star of the day in this case. Which basically, because it's a very short segment, we thought that it's going to be a good wire to use and try, if we're lucky, we go into the true lumen or not. In this case, this was achieved. Once you have the wire in this lumen, we just basically did a POBA, re-establishing flow into that RPL vessel. So this case, in summary, basically demonstrates what the thought process of what wires you pick initially when you try to finish a case. Antegrade wire escalation is the first stepping stone for whatever comes after, and it's a nice thing to actually master that technique before you start building up in other skills. Thank you all for your attention.